Okay, welcome and good evening. Thank you all so much for joining us tonight for the webinar, Sensory Processing Disorder When Everything is Too Much, presented by Felicia Castagna. My name is Katie Delaney. I am the Family and Medical Outreach Coordinator at the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your facilitator for this evening. Now, before I introduce Ms. Castagna, we have some housekeeping notes that I want to go over. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. If you have questions after tonight's session, you can post your questions on the Wednesday webinar blog, which can be accessed from our homepage at www.njcts.org. under the heading Programs. This blog will be monitored for the next 7 days. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now it is my pleasure to introduce our speaker for this evening, Ms. Felicia Castagna. Ms. Castagna graduated in 2001 with her MS in occupational therapy. She worked at a specialized school for children with disabilities before joining Wiseman Children's in 2004. At Wiseman, Ms. Castagna has worked in their outpatient therapy, inpatient rehabilitation, day hospital, home care, and early intervention. In 2003, she received her certification for sensory integration and praxis test, and in 2009, received her certification for pediatric neurodevelopmental treatment, both of which are her cornerstones in her practice and treatment sessions. In 2011, she received her postgraduate pediatric certification. In the following years, she also became a certified kinesiotaping practitioner, brain injury specialist, and service practitioner for ADHD. That is a tongue twister. Ms. Castagna, we are so happy to have you here tonight. The floor is all yours.
Hi, everyone. I'm gonna go through some of these slides fast, just because it's an overview, because I know the meat of everything that you are looking for are definitely more of what to do when you see some of the behaviors, and whether if it's sensory or just behavioral. So the objects are to go through sensory processing, understand the basis of the categories of sensory processing, and then from understanding where they are, where that child is, how to direct interventions that are going to be the most useful for you to get more bang out of your buck. So sensory processing. Sensory processing is the ability to register, process, and use information taken in by all the senses. It allows us to make adaptive, appropriate, and functional responses, and it directly impacts all development and functional skills. So sensory systems, everybody knows their 5 senses. You learn them very early on with naming them. You have your visual, auditory, taste, smell, and tactile. The other 3 senses are newer to a lot of individuals, but they've always been around. Some of them aren't taught. Like when you're taught the 5 senses in elementary school, you're not taught about your vestibular system, your proprioceptive system, or your interoception. Vestibular, proprioceptive, and tactile systems are your precursors to development of visual and auditory systems. With that being said, just so you know, actual visual and auditory systems are developed in utero, but this is talking about more advanced, higher level, not basic criminal, I'm so sorry. Basic reflex kind of systematic needs for auditory and visual. Those three systems of vestibular, proprioceptive, and tactile are what help higher level skills to integrate within your environment. So understanding our senses. Again, I'm not going to go over the top 5 because we've all learned about them. We all know them. We know how to name them. The ones that I'm going to go over right now are your near senses. They're the 3 that I said that not a lot of people have heard about before. That vestibular sense, that is processing movement, gravity balance, and it's all received in your inner ear. This is your movement sense. So when your head moves in space, I can say my ear is going towards my right shoulder. My head is going forward. My head is going backwards. That is your vestibular sense. Your proprioceptive sense is how your body is processing information. So body position, body in relation to objects, and body to body movements. So I can close my eyes and know that I am waving my right hand, I'm stomping my left foot. I know where my body is in space related to the pressure that I'm receiving through my joints. Interoception is a newer contemporary sense, but it's those internal organs and the things that we kind of take for granted, but we don't name, like in the sense of knowing when you're satiated, knowing when you're still hungry, knowing when you're about to have a bowel movement or when you need to urinate. And I'm going to apologize. So sorry, I live in a busy quarter, so if you hear anything, just ignore it like I will and keep on going. But I just wanted to forewarn you. I'm sorry. Again, these are the hidden senses, but we cannot control them, but we can directly observe them. So sometimes you'll see if they, with the interoception, the other one thing I wanted to go back to is these sometimes are kids that don't even know if they're thirsty sometimes. Some of these kids with interoception issues also are the kiddos that might have pica as a secondary diagnosis. And the other thing about interoception, it's connected to your vagal system. So they have they can have some issues with self-regulation internally. So that hot, cold, and those issues. Sensory stimulation. There's no way of living and breathing in this world without getting some kind of sensory stimulation throughout your day. Putting on clothing, whether it's soft or scratchy, if there's an issue with a tag on your neck or your back. Active play when you're playing on the playground or as an adult working out. If you're doing a cardio class that you're doing burpees, you're getting vestibular and proprioceptive and tactile input in just one movement. There's constant music, noise, voice within your environment, which is auditory. You have changes in position. So if you're sitting, standing, laying, rolling, moving in a car, when you come to a car braking, you go forward and backward. That's a vestibular and proprioceptive input. Types and temperatures of food, that is your tactile and taste. And then you also have knowing when to need to go to the bathroom, that's your interoception. So sensory processing disorder. This is a term that's newly coined in the past 10 plus years, maybe going on 15 now. Prior to that, it was called sensory integration dysfunction or dysfunction of sensory integration. What is it? It is when there's a glitch in the system. So when I say a glitch, when I talk to parents and try to describe it, you think about when you have a car and you're trying to turn it over with the key and it's not turning over. So let's say it's a spark plug, that is the issue because it's not working the correct way. Maybe it's not put in tight enough, maybe it's the fuse is gone, but something in the system is malfunctioning. So that's why the car is not turning over and you cannot start that engine. That is what you want to think about when you think about a sensory processing disorder. You have all the working parts, but there's a glitch within that system. So in other words, the technical part is the brain cannot register, interpret, or integrate sensory information to produce an organized response. So this makes learning and interaction difficult. And interacting doesn't just mean interacting with other individuals, it means interacting within their own environment. So Jean Ayres, Dr. Jean Ayres, she's the pioneer, the founder of this frame of reference. She called it a neurologic traffic jam that prevents certain parts of the brain from receiving the information needed to interpret the sensory information correctly. So if you're not interpreting the information coming in appropriately or correctly, the output is going to look not to match what the situation was, or there isn't going to be an output. So think of it that way. So it's a traffic jam, a processing issue, not an integration issue. Processing. There's a glitch in the system. About SPD. SPD is a body-brain processing of registering, interpreting, and integrating sensation. And if you are completely regulated, it goes unnoticed. So that's if you are atypical, a typical neurologically driven person. Even if you quote unquote are typical, that you can have sensitivities like this over responsiveness to sensations. That makes it difficult to fit in an inflexible sensory world, which can be very exhausting, troublesome, and make individuals very pulled back from integrating or engaging in their environment. And then you also have ones that are to the point that they become so overwhelmed and confused by what is coming into their brain, they're being too bombarded because they don't have a gatekeeper that's dropping off some of the sensory information that isn't needed. It's all coming in, so it's bombarding their system. So when it's bombarding their system and they don't know what to focus on, they rarely feel safe because they don't know what to pay attention to and what to dispose of. And then you have the sensory seeking that can be in very inappropriate ways that can actually cause safety issues. I love this little guy because it's a quick insight of some of the issues that can be. I hate having, like when a kiddo comes to an OT and the parent starts listing some of the issues that they see. He hates having his hair washed or cut or brushed. He hasn't had a haircut since he was a baby. He barely gets his hair washed maybe once, maybe twice a week. He is very sensitive to light, so we have to either wear a hat all the time, keep the lights low, or he has to wear sunglasses. He's oversensitive to sounds. We can't go to the mall, we can't go to the movies, we can't go to parties. He chews on everything, so you have to have everything on lockdown and have that person envision in sight at all times to make sure they're not putting dangerous things into their mouth. They touch too hard, not a kiddo that's constantly tapping, but when they are seeking input, they are the ones that are spearing you in the stomach for a hug. They think they're just coming for a hug and they don't realize that it's too hard. Cannot stand or tolerate tags or certain kind of clothes, like they only wear soft things. They never wear jeans. They never wear dresses, frilly dresses. Those kind of things, kids that walk on their toes. So then we have the breakdown of what are our sensory processing classifications. There's three main classifications. You have sensory modulation disorder, you have sensory-based motor disorder, and you have sensory discrimination disorder. So within those, we have subtitles and subsets. Of course, nothing's ever just those three things. So underneath sensory modulation, these kiddos are the what if kiddos. what if we can get Johnny regulated enough to be able to do this? What if we can have the environment this way? Can Johnny do this? That what if kid. He is very dysregulated at most times. This is a modulation kid. There's the four subsets. You have your over-responsive to input, you have your under-responsive, and then you have your sensory seeking, and then you have your regulation disorders. So when you say you're over-responsive, I have a lot of kiddos that are over-responsive to sounds and touch, but are sensory seeking of proprioceptive input. You can be many different levels within that modulation disorder. It doesn't have to be he is just over responsive, she is just under responsive, he is just sensory seeking. It's not that way. They can intermix with what levels of sensation they are processing, and some are processed as over responsive and some are under responsive. Then you have your sensory-based motor disorders. These are your kiddos that are higher level. They know that something's wrong. They can sense that, they know that movement is difficult for them. So you have your apraxis, you have your postural ocular disorder, you have your bilateral coordination, and you have your somatosensory. When you think of somatosensory, you think of a kid that's a bull in a china shop. When you think of dyspraxic, you think a lot more, OTs use the term a lot, but you definitely think more of speech when you think of dyspraxic. Like they cannot formulate the way their mouth is supposed to move for the output of their words. Postural disorders or ocular disorders, these are the kiddos that have, they're kind of the lower level of this subset. They're more of the kids that have visual difficulties and pairing it with postural system, so they kind of are more slouched with their mouth. They usually have an open mouth with a jutted chin, and they have difficulty with focus and learning into their environment. Bilateral coordination kiddos, a lot of times you'll see, oh, he's ambidextric. No, kids are not meant to be using both hands. They're usually unilaterally using their body because they don't have a true midline and they can't integrate their two sides together. Your body does want to use one side as a dominant. That's where neurologically, like, that's what your body wants to do. So these kids have a difficulty doing that. And then you have your sensory discrimination disorder. These kiddos, I'm not going to go too much into detail. I'm just going to go quickly over. If they have a discrimination disorder, it is apparent because it's a high level cortex issue of the brain. You definitely know if they have vision difficulties. It's something that is known. Like you would definitely know that they have eyeglasses, or they also have, when they have vision difficulties, they have eye teaming difficulties. They might have a difficulty with reading and those kind of tracking, scanning. Hearing, think about a kiddo that has auditory processing disorder. With touch, again, these are things that are going to be apparent, like they have lack of smell, they have lack of taste, they have movement and positional difficulties. You can definitely tell. It's not something that you have to point out or investigate like modulation and sensory-based motor kiddos. Behaviors that happen. And a lot of these behaviors you see in kids with autism, ADHD, there's a lot. I just want you to know that sensory processing, there are kids that are truly just sensory processing, but a lot of this sensory processing disorder is linked to many other diagnoses. It's sometimes a precursor to some of them, not a precursor, one of the signs and symptoms within the DSM, yeah, DSM-4. I have 5. I always mess up the letters. I'll tell you that now. That's a little bit of dyslexia. Sorry. So you have your impulsivity, you're underreactive, you're overreactive, distractible. They're clumsy, like your posture ocular kid that I talked to you about before. They're the ones that can't sit in their chair. They kind of, like, you sit them in the chair, they fall out. Kids that are sensitive, they're avoidant, they're agitated, they will hit to get out of situations. Kids that tantrum, poor frustration tolerance, poor peer interaction, emotional outburst, obsessively touching other kids. So understanding sensory-based behavior, these kids have poorly adaptive or challenging behavior seen in children that may be a result of poor sensory processing. You have to be an active investigator of the child's behavior to see what antecedent or what part of the environment is the problem that is causing the disruptive behavior. Anyone that has a modulation disorder, or even our kiddos with the sensory motor difficulties, will present in psychosocial behavioral ways. Their body is trying to tell you that they need something. They're trying to get a need or want, and it's shown in a maladaptive way. And that's the behavior. And as you being an investigator, you're going to say, I saw this kid come up really close to Johnny in the line before he broke out into a tantrum. Well, Johnny is sensitive to tactile. He becomes very on guard and doesn't like sudden movements or unexpected touch that he might behaviorally react. When you think it should be a little problem, he reacts like it's a volcano that just went off. Knowing these things and understanding that can help set up the situation later that I'm going to use spots to line them up in line so no kid is on top of each other and it doesn't cause any behaviors for kiddos that are sensitive. Reasons for behaviors. They want big thing for especially sensory kids. They are seeking a specific need. They just don't know how to communicate what they need, because a lot of times they can't even tell, their body isn't telling them, I need to jump and crash. I need to hug somebody. I need to crash in the beanbag. I need to have dark lights. Their body usually can't tell it. That's why they're seeking it inappropriately, and they don't know how to communicate it. Us as adults are the ones that are going to help them learn how to use communication in any means necessary to show, like, this is what I need. Like, I need a break. I need this. This is a huge reason why the behaviors are happening. And the behaviors are happening is a nervous system response to environmental stimuli. I want you to know sometimes these environmental responses can become a learned behavior, because if they're getting something more out of just a sensory need, it can become a learned behavior on top of a sensory processing problem. The emotional impacts that happen with sensory processing disorder. A lot of these kids, especially around 7, 8, they really start to show social isolation, suffer from low self-esteem, high anxiety, especially our kiddos that are super sensitive early on in life. They definitely show high anxiety. They definitely are at high risk for emotional, social, and educational problems, including the inability to make friends or be part of groups, poor self-concept, academic failure, being labeled as clumsy. So think about the kid that's never picked in gym class. Uncooperative, disruptive, or out of control. Later in life, or even early on, like a lot of our kids, if you've seen the trend, are being diagnosed with generalized anxiety disorder at, gosh, where my youngest I think was 7 or 8. Depression, aggression and other behavioral problems. And even later on in life, there is a high incidence if some of these sensory processing disorders aren't taken care of or are not appropriately found strategies to help within the situation have led to substance abuse and drug addiction. That's definitely on the higher, the broad spectrum end of it, but it has been linked in research. So I love this chart. This chart really helps you see the delineation here. You have your behavior-based meltdown and you have your sensory-based behaviors. Look in the middle. They both present the same. You have your screaming, your kicking, your shouting, your stomping, your swearing, biting, throwing. I mean, I don't know about you, but I've gotten some AAC devices thrown at me at times. I've gotten kicked or punched. It happens. They pull your hair when they're agitated. Again, the behaviors present the same. The big difference here, let's take the behavior-based meltdown. It's driven by a goal. They want something. They need an audience. You take away the audience, it usually ends. Or if they get exactly what they want, the behavior ends like that. There's no autonomic nervous system signs. They literally can go from 100 to 0, no problem. Like they didn't even miss a beat. When you have a sensory-based behavior, it is driven by something. They are reacting to overload or being overwhelmed. They don't care if anyone's paying attention to them. You can literally put them in the corner just to be safe and let them be. They're still going to have that behavior because it has to run out of their system. There is no goal to the meltdown besides getting out that energy and frustration. You will see an autonomic nervous system response, and those signs are if the child turns red, if the ears turn red, if they start to sweat, if they flagellate, their pupils are dilated. Even if the behavior seems like it's calming, it will take up to 45 to 60 minutes for that child to become calm, completely calm, internally and externally again. And that is a nervous system response. So to see what the differences are, they present the same, but you have to look to see what happens during that behavior-based. Then we have our sensory processing intervention. You have helping the parents, teachers, or caregivers understand the sensory difficulties that are leading that child's behaviors and fostering the relationships between the child and significant others. So you're helping them see the child behaviorally where they are now and what sensory systems they need to help them, and trying to explain the verbiage to the caregivers too, so they can better understand the child. Modifying the environment to fit the child's needs is another huge one. And then also providing direct individualized intervention to meet the child's needs. So in other words, nothing is cookie cutter. One thing that might help one kid will not help another kid. You have to find what is going to help each individual kid. So working together as a team. Something from, she's actually, I forgot to put PhD. Lucy J. Miller is a OT and a PhD in neuroscience. She is spearheading so much information and research about sensory processing disorder. She has a great book out that is in my references at the end. Everyone deserves the best support we have to offer in order to flourish. So even working off of IDEA and IEPs and IFSPs and so on and so forth, kids need to thrive within least restrictive environments and have the best possibility to thrive in any environment with supports. Meaning they should not be taken out. What can we do to help them within the environment excel? So from there, we have how to, using sensory stimulation to enrich experiences. Things that we do every day. Think about it. Think about when you start to feel tired or it's going to be a long day. What's something you could do? I know as an adult, I will exercise in the morning to get myself ready. I need the heavy work. Midday, I may need a coffee because I'm starting to get tired. Right now, I can tell you I'm tapping my foot, or I'm playing with my ring, or I'm talking with my hands. These are things that I do to get myself through. Think about our kids. They're kids. They have other ways that they need to express. They need to move more than we do as adults. They will want to go to the playground and swing. They'll want to climb. They'll make forts and climb over furniture. They'll sing. They jump around. We can also use weights and compression. I know I do better with heavy work. So again, knowing your own system, if you know how you get around and how you regulate, it's going to help you better understand the child or adolescent or adult that you're working with to understand what their needs are. Effects of sensory stimulation. The effects we have increased or decreased arousal. We have shutdown versus hyperactivity. Things that you never want to see as a neurological shutdown. These kids are to a point that they are in fight or flight, that it's to the point that they need to shut down because they feel like they can't handle anymore. When a kid truly neurologically shuts down, it can take hours for them to be up and running again. So we try to avoid that at all costs. And then you, of course, have those hyperactive kids. He's just bouncing everywhere. He can never sit still. Then we have another thing with the effects of sensory stimulation is effects of sleep-wake cycles. We have kids that do not sleep and they've never really slept through the night, even as babies. Think about lack of sleep and what happens to you. If you have a lack of sleep, you become agitated and frustrated so much easier. Think about our kids that don't have any strategies like we do. We also have sensory stimulation for calming effect. We have it to improve organization. We also have it to improve attention, skill development, and social interaction. If you can have somebody regulated, that means that their arousal system is at that just right level. If it's at that just right level, they have that attention. If they have that attention, they have a capability of learning. That's what we want our kids to be able to do. We want the kids, or even adults, because we can learn throughout our lifespan. We want them at that just right level so they can learn. Sensory regulation is, again, it's the ability to respond or adjust appropriately to sensory stimulation. It is called an adaptive response. Regulation needs to occur in order to attain, maintain, and change one's own arousal level to meet the demands of an activity or situation. We already talked about what we do to self-regulate, and I gave examples of what I do. Knowing what you do is going to help you understand why your kid is doing, or again, anyone that you were with or treating or care for. If you can understand yours, you can start to look at their behaviors of why are they doing that? What are they getting out of that? When we start to think about what things can help that child when they're having a difficult time regulating and meeting that just right challenge. Self-regulation is the ultimate goal of sensory processing disorder intervention. We want that child to learn how to be accountable and self-aware of their sensory and environmental needs to achieve and succeed within their everyday lives. The key is beginning to identify your own emotional state. self-awareness and helping the child understand their emotional state. So self-awareness, what I mean from that is that we gotta start to help the kids understand where they are emotionally. There's some strategies that are in the next couple slides that I'm going to talk about and just present quickly that help kids become self-aware. Through that self-awareness, we start to label with certain names. When they become more self-aware, they take accountability of their emotional state. What is causing that emotional output? What do I need? If you see where I'm going with that, we start to help them learn as we're learning them too. So they have that accountability state that's happening where they're going to learn strategies to help their own self-regulation. And the big key is, and it's a hard one, the caregiver must be aware of their own regulated state in order to help an out-of-control child. If your child, or again, an adolescent adult, age span, if they're all the way up here, this high zone, like out of control, tantruming, if you're at their level coming at them and you're agitated and high and about to bounce through the roof yourself because your heart rate is up, you're starting to have an autonomic nervous system response and you're getting flushed, how are you going to help them calm? How are you going to help them turn it around if you are as high as they are out of control? So knowing when you need to help you bring you down to a just right level so you can help in that situation. So learning your own self-regulation is what's going to help their self-regulation. I hope that makes sense. Because again, if it's like one feeding off the other. Kids, even if they're nonverbal, can pick up on others' energies. If your energy is running high, they're going to pick up on it. And they're already out of control. Where are they going to feel safe if you're out of control too? Because all kids just are, when they're dysregulated, anyone wants to feel safe so they can bring themselves back down to that calm state. Sensory dysregulation. Dysregulation is kind of not talked about that much because sometimes they're like, oh, well, he's just having too much fun. That's why he's laughing so hard and he's speaking so fast. And it's like, well, no, this is his body trying to tell you he is out of control. He needs help to bring it back down. Laughing, uncontrollable laughter, hard, fast movements, loud voice, meaning you're in a library and they are screaming. They can't moderate their voice at all. Unable to follow directions. If you're dysregulated, your arousal system is through the roof. If your arousal system is through the roof, that means your attention is down here. It's down here, you're not learning. You can't pay attention. You're not getting in the information from your system, the verbiage of following verbal directions. They're impulsive, excessive saliva. So kids that might drool are all of a sudden like drooling a lot, screeching and high-pitched yelling. And behavioral strategies. I just wanted to bring this up too and bring in Tourette's too with this. The main thing that I tell anyone that I come in contact with, no matter what, make your behavioral strategies as positive as possible. Create that positive environment. Create a environment that you do not shush or tell them no or stop that. Show them other ways of presenting. Know when to ignore and just keep going. And know when to make sure you praise all the good behaviors. Establishing the simple routines, use of a schedule for our kids that are sensitive. They need to know what's coming. They need to know when there's beginning and end. Be consistent. If you say there's 3 more, there's 3 more and you stop. Use simple, specific language first, then to more than all done. Make your expectations clear. Use a timer if needed. And then also some of our kids do need a sensory motor support to help with transitions. They need to transition from one activity to the other. They might need a movement break. Knowing these things, being consistent and keeping it positive. So I have kiddos, just for an example, if I have a kiddo that is self-stimming, and I know their body's excited and all they can do is this, I'm not gonna say, no, no, no. I'm gonna go, oh my gosh, Johnny, I see you're so excited. I'm gonna give pressure into the arms, into the hands and say, let's clap, we got this. This is awesome. I will never say, don't do that. So knowing the kind of terminology and keeping it positive will go a long way. So again, I said we were going to go quickly through these because you can look into them. There's 2 programs out there right now. There's the alert, there's probably more, but the 2 that I use or refer to, especially with the practice that I've been in the past 20 years, this is what we've used. The alert program, which was originally established 35 years ago from 2 OTs for 8 to 12-year-olds, because cognitively that is where you can process all 3 stages. But it has been adapted, and you can use it for two years and on, but you just modify it. And then of course it could be used through the lifespan to older kiddos. The alert program itself goes on how does your engine run. You have 3 levels. You have high, just right, and low. When you have your high, low, and just right, that just right level is something that you want your kid to be at, or your adolescent to be at, for times of education, times of working together as a team, ability to have dinner together, just right level to go walk into the mall and go to a store. When your engine's too high, it's when you're at the complete extreme, it's like a volcano erupting, but in between that, you have the gray areas. You see there's big gaps. It's a big pie piece. There are that gray areas that you are in between just right and just right and a high. That is that excitable stage. You're not to the point that you're too high that you're about to explode and like a volcano, but you're excited, because kids get excited. Everyone gets excited. I'm going to the Foo Fighters concert. It gets me very excited. So I'm allowed to get excited. It's knowing when you need to be just right for those other times to focus of how do I get my engine back to just right. And that too low is that sick, bored, sad. They're too low. And then the next thing is zones of regulation. Zones of regulation came out in 2015. It pretty much plays off of the alert program. This one only puts in that in-between zone that I told you about, that excitable zone. They put in the yellow zone. So you have your red, yellow, green, blue. Again, green is where you want your kid to be, or the person to be, for that optimal learning. Yellow is where a lot of people function at times, because being silly, being excited, having anxiety, having frustration, having stress, having the wiggles, a lot of people perform there. It's knowing when we need to come back down to green and what do we need to get there. So, or if we're under responsive kids that need more input to get them to be alert, that blue zone, what do we need to do to amp their system to get them to green before they need to participate in something important? So these are examples of ways of using zones of regulation. A lot of classrooms have used and adapted this and adapted the terminology. The big thing with these programs is all about self-regulation. It's helping them become accountable for how they are feeling and how they are emotionally doing and how they are showing their output within the system, like what are they showing the world? So self-regulation within these parameters of the two programs, there's three parts of it. You first have to learn the vocabulary. Two, you have to learn the feelings that coincide with the words. So they need to start being self-aware and or accepting that adult facilitation of where are they on that barometer of emotion. Are they high, low, or just right, or red, yellow, green, blue? And then the last part is that they learn strategies to assist in changing the levels of regulation. What will rev their system up when they need it, what will slow it down, and what helps them best increase their attention in the moment. Sometimes kids never independently get to step 3, and it could be a cognitive issue, it could be an age issue, and they can still succeed within those programs with external assistance for step 3. So quick things about what you can do if you have a child with over-responsiveness. I try to list a bunch of different things so they are in your handouts, but if you have a kid that's over-responsive, that means they're hyper-responsive. That means they do not like that input. Things that you can do is you have for auditory, you can use soft voice. You could play soft, low music in the background, white noise, wear headphones, play I Spy with waiting games. So the idea of playing I Spy is that you distract them from the input in the environment, meaning by them cognitively looking for things and visually attending, it dampens their sensitivity to the sound. You're telling them to override it by getting them engaged in something else. With visual, you can dim the lights. You can use natural light instead of fluorescent lights. Wear a baseball cap. Use a screen protector, like the visual dimming one for laptops, because sometimes the light of that works, helps. Proprioceptive input. Proprioceptive input, especially with kids that are over-responsive. Isometrics is a good way of helping them. Isometrics is getting something to like a 90 position and holding, like a wall sit or holding their arms, holding a tray kind of thing. Working out with weights, chewing gum, asking for hugs if they're allowed. If you're not allowed to give hugs within a school situation, having beanbag chairs and asking them to be squished in between. Wearing pressure garments. A lot of the kids that don't like touch will ask for pressure garments because it's a passive way that they can get the input without having somebody touch them. Weight. I'm going to say this now because it's again for over-responsive or hyper kids. Whenever you use weight, this is my soapbox, do not use it for more than 20 to 30 minutes at a time. So if you put 10% of that child's body weight on them, you only let them wear it for 20 to 30 minutes. You set a timer, either your clock, if you have multiple kids in your care, have names with kitchen timers that you can program. Make sure that when it goes off, you take that weight off and you do not wear it again for 2 hours. Because if you continuously wear that weight and you do it like say circle times an hour, I don't know why, but I'm just saying it, and you let that kid wear that for that entire time, if you continuously do that, that kid becomes so accustomed to it that you just gave away one of your strategies because the body became too accustomed to it that it doesn't even work anymore. So try not to. Giving fidget toys for tactile kids, having self-directed tactile as they can tolerate it. I'm so sorry, I have the word tolerate, as they can accept it. Vestibular, being able to rock in the chair, taking exercise breaks of reaching for the sky and touching their toes. That is a quick way of getting vestibular input without taking up a lot of room or needing a swing. For under-responsive, you have those kiddos that need more information in their body to be able to register input in the world, or like them in the world or them within the environment. These are kiddos that need things not to be slow paced and rhythmic. These are ones that want that fast, slow, fast, slow. They want something not to be predictable. Using brighter lights for our visual kids that are under responsive, using deep, quick strokes of pressure for proprioceptive, using a massager if they're allotted to be able to use a massager. Some kids cannot use a massager, especially if they're prone to seizures. Using fabrics or materials that they can do light, quick touch with, because that'll prep their system. It's obnoxious and anoxic for kiddos that are over responsive, but if they're under responsive, they love that light touch. And then things that need to be unexpected, frequently changed to increase arousal. They are kids that you constantly have to change things. For vestibular, you can have them run short distances in a hallway. You can use the, it's called like a disco sit. It's like a little half deflated ball that they can sit on and they can still wiggle. You can have animal walks, bouncing on a ball. For oral crunchy, you want, especially if they're under responsive, you want some pungent taste with their lunches, or hot sauce, things with hot sauce, sweet, spicy, ability to chew gum for short periods of time to help prime their system and they have to throw it out. You can use smell for under responsive. With anything like them, under responsive kids, you want to use things that elicit attention, so strong smells like mint, citrus. And then you have your sensory seekers. Some of the things overlap as the same as your under responsive. The only thing I would tell you with the sensory seekers, you want to make sure everything is timed. These are the kiddos that you do need to put parameters of goal-directed activities and timed activities, because you don't want to give them too much information. You want their system to learn how to deal with information in short periods of time and start to accommodate to it. And then their body will start to change, because if you are doing the right kind of input into their system, they will show changes and become more calm overall, and the seeking part will diminish. With smell, I've used sweatbands that I use essential oils, make sure it's essential, not synthetic. I will put lavender or vanilla, and I'll have it in a baggie in their desk, and they can take it out and put it on when they're having a moment of stress, or they know their body needs to move. They can put it on and use that as a calm. Again, weighted fidgets. Fidgets are huge for these sensory seekers. Also, putting an elastic band around the base of their chair will give them tactile and proprioceptive while they're sitting, so they can stay in a seated position but still get a lot of energy out. Sensory-based motor disorders, a lot of things with these are the kids that know that there's something not right, but they can't put their finger on it. You have to really help with building self-esteem. You have to work on core muscles and strengthening those anti-gravity positions like Superman, the ice cube kind of position, like you're on your back and you're trying to hold everything together. Weight-bearing resistive activities like wall push-ups, yoga positions, anything like that is going to help with them. Activities that are, like Simon says, or any component of timing of sequencing. So like if you think of a component activity for timing and sequencing, think about red light, green light. That is something, because they have to listen at the same time, so it's an auditory piece too. But that is some of the activities that you can do with these sensory-based motor kiddos. And our discrimination kiddos, again, these are kiddos that you know that there is something, because you can apparently see that there's something there. So these kids might need vision therapy. They might need FM systems within class. They might be kiddos that might do well with an auditory program. Also, These are kids that might do well with exposure therapies to certain tactile input or oral input. Things that are sustaining balance and positioning, things that are same in different games. That's a good one for visual. Big thing to tie up. Key things to always remember about sensory processing. Current research shows that neuroplasticity is ever changing through the lifespan. With that being said, old practice was that once you turn 18, what you got up here is what you have. If you get in an accident or something else, it's gone. It's not true. Your brain finds a way. If you give it enough input and you have the internal motivation and desire to do certain things, a new neural pathway will create. And again, it might not be perfect or typical, but there is ways to enhance that neuroplasticity. We have to take advantage of it by using our sensory systems. And the ways that we can change it is by completing activities with frequency, duration, intensity, and variability. Those 4 things are the way we change any sensory system or processing system throughout your body. And then also the need to become an investigator. Oh, one other thing I wanted to tell you about frequency, duration, intensity, and variability. If it takes, on an average, 1,000 tries to learn something, to learn it, to become everyday routine, like knowing, for some of my kiddos, that knowing how to brush their teeth and knowing what components to get, like inside, outside, up, down, tongue. It takes about 1,000 tries. Say they're doing it wrong and you're reteaching them how to do something, it takes up to 5,000 times to learn it, to become everyday practice and become habitual. Just so you know, I wanted you to know the numbers because it makes it apparent of things that you need to do and why it takes so long sometimes for somebody to learn something. With kids that have those sensory behaviors, you need to become the investigator. You start to plot out, take a journal, understand, like, why is it happening here? Is it a certain time of day? Is it a certain trigger with a certain kid? Is it, or a certain environment? Is it a certain, they know a certain clothing is coming because they're going to dance and they don't like tights. Like, start to plan that out. When you have those things and you come with those plotted out times a day, when you bring that to a professional like an OT, we can help you work through what can we do next. Knowing all this, because you're with them longer, what are we going to try to see what's going to work the best for this child? So we make a sensory program that is going to work and be most beneficial to everyone involved. And then remember, again, we're not cookie cutter. Each child's different and will have different needs. And just so you know, with a sensory system, if you change one thing, it might be ever changing. Just by changing one thing might not make them quote unquote integrated and processing fluidly. It might lead you to the next thing to work on. Everyone's beautiful the way they are, and just learning how to help them have the best life they can have in the least restrictive environment. That's everything. If there's any questions, I would definitely love to answer.
First and foremost, Felicia, thank you so much. I know that we are currently at 8:30. For anyone that needs to log off, we completely understand. We're going to stay on for a couple minutes after just to answer a few questions. If you do need to log off, there will be an exit survey. We would greatly appreciate if you filled this out. This webinar will be archived to our website at www.njcts.org, and the webinar blog will be open for the next 7 days. We will be having a webinar next month on misophonia titled Stop Making That Sound by Dr. Marla Deibler on February 15th at 7:30 p.m. And for those of you that can stay on, we have a couple of questions and I'm just gonna start asking. You ready? Okay, so we have, someone said, I have a student who, when dysregulated, paces my room, scripts, and does not process any auditory input. I could repeat myself 10 times, but he just continues to script. He has so much potential, but I don't know how I could help him process input. Do I increase the time I give him to process input? This is kind of long. Do I give him some sort of regulatory activity prior to starting my speech therapy session with him? Aside from ASD, can scripting be a symptom of having a processing disorder? And then they said, I don't know I don't know the clear antecedent or what his sensory needs are.
So if a kid is pacing, if it's, I understand she said she doesn't understand if it's a clear antecedent, but usually the pacing is coming from something. It's either avoiding or seeking. Finding out that and trying to figure out how you can, in the most positive way, interrupt that and move them to something else. Try that slight little body block and say, oh, hey, you know, and like try to bring them back to you and lead them somewhere else for something that you need. If we know and we can plot if it's a certain time of day or a certain thing that's about to happen that the pacing starts, knowing to try to give a little input or a countdown or something to help them understand what's coming next is another strategy. So knowing the difference between those two. Also, things with scripting, things that I've tried is that I tried to interrupt in the sense of ask if I could pick up what they were scripting, like, oh, okay, it's a SpongeBob show. All right, can you tell me something? Like I try to engage in it, and then usually by me trying to engage, it usually sometimes has broken the script that I can get to them. Sometimes I have to let the script run through and then I can alternate through to the next thing. A lot of times if I am trying to distract and I know the scripting isn't going to stop because there are some kids that are on a constant loop, I will try to do that body block, give some firm input on their shoulders or onto their sides of their arms and allow them to know that I'm in their space and that, okay, we are going to move on to this, and then give them a second to process that. Because again, in their head, they're looping. So you have to wait for them to register that input, because sometimes that physical input will help break some of that that's going on internally in their brain.
Thank you. So our next question is, can you provide feedback specifically for preschoolers? They didn't really give an example or anything.
Okay. Well, preschoolers, a ton of different things you can do. So like if you think of preschool, you think of one of the major hard things for most preschoolers are circle time. Circle time, a lot of times what you can do is use spots on the floor if you have difficulty with kids staying within their own spots. I've used kiddos that have spandex, like little cocoon, little things that they sit in so that it helps them understand staying close to their own body and their own bubbles. Other things, using animal walks or some kind of motor movement before getting into circle time to help dampen some of their seeking, getting out some of that movement prior to sitting and trying to get them to attend. No kid that young is going to be able to sit for a long period of time. Having movement breaks within circle time, having ability to have fidgets or things that they can play with their hands, and having ability for each kid taking a turn of participating so they can be up and moving. Some quick ones, because I know that in preschool, that's usually one of the big things that I hear are the most difficult for the children that I see.
Good to know. And our last question is, what is the best way? I lied. We just had someone else put in another question. I love it. Okay, so second to last question we have, what's the best way to explain to family members or friends that behavior issues aren't just bad behaviors? Some people look at it as the patient is too lenient or can't control behavior.
The best thing I can say is educate them. You can't, unfortunately, help everyone with their preconceived notions, but education is the best key to defend against some of them. I have a lot of friends that do have kids or with ADHD or autism or other genetic disorders, that education has been key for them to feel more accepted within environments. Because again, you want to be able to be out and about. Also knowing when to let other things roll off your back as a parent, because you know you're doing the best you can, and letting it be that way because you know you're doing the best you can. Because I know it's hard as a parent to do stuff like that, but all I can say is education and knowing you're doing your best and knowing that your child is succeeding and working through a lot of things.
It's really, really good and important advice, and thank you for that. And so our last question is, this person says, I am a speech language pathologist and I have a student that has a lot of sensory needs. However, we cannot seem to determine what the input, I'm sorry. However, we cannot seem to determine what input he needs. We have tried many different ways to provide him with the input he needs, and I even co-treat with the OT for one of my sessions. For example, we had him on the swing last week and he seems to become calm when swinging. However, he shows signs of frustration through crying after a period of time, but did not want to get off the swing. Any ideas?
So if they're trying to do, if I'm listening correctly, is that they're pretty much trying to do a session on the swing. So trying having it timed and taking the swing down. So having a timed part, having the swing down, do an activity, go back to the swing, like a first and then, and do it. At first, it's going to be a fine little dance, I call it, especially with mentoring newer therapists. It's a little dance you're going to do. You're going to do, all right, we're going to do 10 swings, stop, work, then swing, work, then swing. And then, okay, we do an activity, and it's a low level activity because you're just trying to get the buy-in. And then you do, again, 10 swings. And then you do that same activity, or you do the next part of the activity, and then you get the 10 swings. As he's learning that back and forth, the next time, or even within that session, if he's doing well, then you start to do, all right, you still can have the 10 swings, but now you have part one and part two of that activity before we go back. So you keep upping the ante as they start to show that they can understand the back and forth. So it's that fine dance of what's going to work there, that back and forth, but always giving that back and forth until they don't need it anymore. It's, again, I call it that little dance that you do within a session.
Thank you so much, Ms. Castagna. And thank you, everybody, for joining our webinar tonight. So it's around 8:40. We're going to close it off now. If any of you have any questions that we weren't able to get to, our webinar blog is now open. Feel free to go onto our website at www.njcts.org. It'll be right underneath the archived webinar, or this archived webinar. And Ms. Castagna will be able to answer your questions for the next 7 days. In addition, there will be an exit survey. Please take a moment to complete it. We would greatly appreciate it. And like I said, an archive recording of tonight's webinar will be posted to our website, and the webinar blog will be right underneath it. Our next presentation will be Stop Making That Noise, presented by Dr. Marla Deibler on Wednesday, February 15th at 7:30 p.m. Eastern Standard Time. This ends tonight's webinar. Thank you so much, Ms. Castagna, for your presentation, and thank you to everyone for attending. I hope you all have a wonderful night.
Bye.